Good evening and welcome to all on this webinar on data sciences in healthcare. It's indeed we have a very respected and well-learned panelists with us. I'm going to introduce you all of them over a period of time now. I uh, deep-heartedly I welcome all the panelists. We are in fact very much. It's one of the excellent knowledge evening we would be having with all of them. I extend on behalf of Asian Institute of Design a hearty welcome to all our panelists. So we will start a few sessions before we would like to start. Certain do's and don'ts. Basically, this is being you can use the participants can use chat box to interact. You can use question and answers icon to ask questions to the respective speaker, or you can have these questions for all of us. There is a person who is basically taking all your questions, and we would be streaming these questions to our respective panelists. The session is being recorded, and it started recording from the moment I started live. Then this is currently streaming live on YouTube. Just to all of the participants, I welcome you all. Thank you very much for we respect you had other options, but you have taken this option to know the field of data sciences and know the field a bit of artificial intelligence, what's happening on the other horizon. Sit back, relax, and enjoy the webinar. This webinar is being presented in collaboration with Enopoya University, YRC, HSJD Hospital, Barcelona, Indian Institute of Public Health, Shillong, and SRM University. In fact, we thank all our collaborators in coming towards this webinar and giving us knowledge on artificial intelligence happening in the sphere of public health. A brief background about Asian Institute of Design. We had a higher education college offering multidisciplinary degrees and diplomas in new age careers with a strong industry engagement and academic standards with emphasis on student-led learning. So we have an hybrid faculty who are basically who are industrial professionals and also educationalists and entrepreneurs. So it's not just only theory, it's theory plus practicals. And students, we have many students who have credits in creating blockbuster movies and top international games. So we have one of the distinguished alumni students as part of our educational institute, which we are running this program for past 14 to 15 years. In fact, we are connected on all the social media, the Facebook, the Instagram, YouTube, Twitter. You can follow us on LinkedIn, everywhere. We have a website, dedicated website, asianinstituteofdesign.in. As part of aided learning, so we are running this webinar for skilling and reskilling as a constant learning and unlearning. So we know life knowledge or learning and unlearning doesn't happen at one phase, but it happens throughout our career, throughout our work life. So aided learning intends to connect reputed educational institutions and industry experts worldwide. This series will hold webinars, conclaves, panel discussions, and various other forms of knowledge sharing and expertise, which is accessible to all the stakeholders of this concept. So our main purpose for this thing is knowledge for everyone across the globe, and during these pandemic times at the convenience of their keyboards. So that has been the motive and interest behind this aided learning. So we will start this session now with a wonderful evening, a 1 hour knowledge session with the distinguished panel members of us. We have Dr. Joseph, Mr. Arnav, Dr. Ranjit Das, and Dr. M. Prakash, and Dr. Eliza with us. Just giving you a brief introduction of all of them. First, we'll have a presentation with Dr. Joseph and Mr. Arnav, then followed by Dr. Ranjit Das, then followed by Dr. M. Prakash, and finally by Dr. Eliza. So I would be introducing all the speakers just before the start of their presentation. So right now we will have a presentation from Dr. Joseph and Mr. Arnav. Uh, Coming to Dr. Joseph, Dr. Joseph is a radiologist, and he has a doctorate in neuroradiology. He is head of quality, innovation and research at Diagnostic Imaging Service in HSJD Hospital, Barcelona. His main area of scientific interest have been venous biomarkers in brain ischemic diseases, which has been the focus of his doctoral thesis. Uh, Currently, he works as a radiologist at SJD Hospital de Mar, and he has headed. He has been the head of MRI at German Streiss Visual Hospital, and he was a medical director of the Institute for Diagnostic Imaging. So, welcome, sir. Welcome, Dr. Joseph. And Mr. Anna is an innovation engineer. He is head of 3D department and project manager, SJD Barcelona Children's Hospital. He's been R&D engineer at HSJD Hospital previously, and he's a lecturer at Health Barcelona and a researcher in innovation and entrepreneurship. We extend a very warm welcome to Mr. Dr. Joseph and Mr. Arnav. So sit back. We are going to have an engaged session from Dr. Joseph and Mr. Arnav. All to you, sirs.
Thank you. It's a real pleasure to be here. I'm Josep Monuera.
And I'm Arnaud Wiles. It's an absolute pleasure to be with you today, explaining what our experience and what we do. So first of all, thank you for all the organization in the Asian Design Institute. And I'll be sharing the screen to share my presentation. Can you see it now?
Yes, doctor, we can see.
Great. Our talk of today will be focused on data science in healthcare, and we want to start explaining our experience. We are a pediatric and maternity health reference hospital in Barcelona, Spain. We are one of the top 3 in terms of activity, so amount of patients that we treat every year in Europe. And we have research nationally and internationally with various projects in AI and also in clinical research. Another thing is that we are a university hospital, and for that reason, we are linked to the University of Barcelona, and we also developed classes for new students in medicine, in pediatrics, specialties, and also in nursing, but also in other knowledge like AI, 3D printing, or other technologies that are now and more helping on the world we are now in medicine to help in clinical decision and clinical support. And that's what we wanted to start. If we look at the trends, we see that Forbes in 2018 stated what would be the 8 next specialties that will arrive in medicine field. And the number 1 was stated to be the reconstructive surgery 3D printing specialist. The second, the voice assistant healthcare content specialties. The third, the robotical clinical documentation. And then there's one that for us always it's funny to see also, which is the biological terror, the number 8. But talking about the skills, the health IT analytics the same year stated what would be the skills that physicians and nurses and clinical specialties would need in the future. And if we focus on those skills, we see that from the top 12, 7 of these skills are related to artificial intelligence and data science, being the second, developing the next generation of radiological tools, focused on AI, of course, creating more precise analytics for pathology imaging, bringing intelligence to medical devices and machines, and turning the electronic health records into something reliable and a risk predictor, between others. So we are in the moment and the time in which we can merge engineering and medicine to do our best for our patients. And that's also what other publications did in the last years. In terms of medical imaging, we see new trends focusing on how big data is used, or 3D printing or virtual reality for the help of the work done in the field of radiology. And more focus on AI, for example, being a paradigm that is shifting, thanks to this new technology, the way radiologists are working and will work, the way we will do the decision taking, and the type of people that will collaborate and work together in the first front field of medicine in the hospitals. Basically, one of the three main tech innovations in AI for imaging would be improving the screening in diagnosis, making understandable data, and improving imaging acquisition and reconstruction. So taking all those things that now are done by radiologists and imaging, but that don't bring great value to their work, could be co-worked, so co-developed with machines and artificial intelligence algorithms, so that the professionals can focus on the final diagnosis, on the patient, and on bringing the best health and care to each person.
Sorry to interrupt you, doctor. Can you just switch on your video, please? Thank you, doctor. Sorry to interrupt you.
Hi.
Yeah, thank you, doc. Thank you.
Good.
As we were talking, if we imagine how image has developed in the last year, this is the main pathway that radiologists and imaging specialists works 5 years ago, and from the creation of the radiology departments until now. The patient has a clinical need, suspicion. Then there is an image acquisition using any kind of image, such as MRI, such as CT, ultrasound, whatever. And then there is a result, an image interpretation from a specialist who makes a qualitative interpretation of the results. And what is the results nowadays? Nowadays, we found that there is new skills, new roles, and new outcomes from the digital image. We know that we have yet patients and clinical needs, but today we have new roles inside the departments and inside the hospitals, and also collaborating with university, such as engineers, such as bioinformatics, and even designers that add some new information. And this is just focused, for example, in segmentation, on even in validation. And thanks to these new roles and new skills, we have not just reports from qualitative interpretation of a specialist, but we have new information. And this is the 3D imaging, the virtual reality, but also the 3D printing. And in the other area, we have the AI and image quantification. That means we have not just a qualitative interpretation of images, but we have data, and real data that we can use and mix with and mesh with the other data in order to have new data science to explore and to extract new conclusions that are new and different from those classical that comes from the visual interpretation of humans. And that's where we are focused in these new outcomes that are just preparing to be used in every hospital around and university around the world. Let's explain in some examples in our hospital what we do. This is the example of the AI tool that we have in emergency room. Each patient who arrives at hospital, we scan, we make a chest X-ray, and then we use an AI algorithm in order to detect 4 different pathologies. And then we use as a screening. That means that once the AI detects something, the radiologist and also the radiographer look and confirm if this is a real pathology or not. That means that we are collaborating with some companies in order to improve this AI in order to make a rapid and fast diagnosis before arrive to the referral doctor. Another example, and as I now explained, it's for us it's very important to have understandable data. And this is an example also in patients with a vascular disease in brain. And if we compare the first line and the second one, maybe it's difficult to see differences. But if we look at the last images in color image, we fast identify that there are differences between one and the other. There are more number of vessels. These vessels are faster, changing color, and this is easy to understand and to explain to the specialists such as neurologists or neurosurgeons in order to explain if this patient is going well or not thanks to the treatment. And that's, for us, it's also important. This was a Python algorithm that a student from the Polytechnical University of Catalonia, that it's also a partner of our hospital, developed in order to prepare this data in order to understand faster and better compared with the classical view.
But another big challenge that we face in healthcare is that in the last years, most of electronic health record in data that was gathered in different silos and focused basically on being used as a record of those data, but not focus on analytical and the analysis and the artificial intelligence developments that would be done afterwards. That's why 4 years ago, we started to develop a data lake in our hospital, in focusing on mixing all these siloed data in common standards, international standards, and having a data lake in which we could go to improve clinical support, clinical decision taking, developing algorithms for innovation and research, scaling up and doing this process as fast as possible, but also for data analysis, looking to the data of different patients and from different origins. With that, we could fast develop solutions as the ones we saw and showed you just a minute ago. But also we can improve research, mixing researchers and the clinical data easier. An example of that is how the health data manager or our data lake help on the fight COVID-19. What we've done is that a project that is called Kids Corona. You can enter the website that you see downstairs, and what we did is we take 17 studies that were done in our labs in genetics in different fields, and that were focusing all on the same question: how COVID-19 is affecting pediatric patients and women, and also on fetal level. But the challenge here was how can we mix the data from these different 17 studies to get new outcomes, new ideas on how this disease is affecting our patients. That's why we used the HTM, and it's an open data based on GDPR compliance and security, so that we can also collaborate with other research groups and universities that want to bring their data into this platform or want to participate in the research that we are doing. But one of the challenges that we still face on healthcare is going and using all these technologies, closing the gap between engineering and medicine to mix and help not only on diagnosis and treatment, but also in patients at the end, from home to home, using monitoring devices, data gathered in the hospital, and everything together to bring the best health to each patient. But for that, we need also new business models, and that's why we are also focusing on the way of implementing value-based healthcare initiatives to make these artificial intelligence tools a reality.
And Another important point is to recognize that these skills are new and professionals need to be trained in these new skills. That's why 3 years ago, we started with Arnaud to design this course that we call Expert3D. And this is in reality, is a comprehensive course of transversal imaging post-processing, and we focus in 3D printing and AI applied to medical image. This course focuses, as I said, in a training in order to acquire skills, in order to understand what is the medical image, how we need to prepare and process this image, and then focus in two main areas, 3D and AI, data science of medical image. And what is the solution? This is a real daily practice solution. So we design 5 modules, not according to the silos of knowledge, but according to the pathway of the real needs. That means we need to explain to the students to understand what are the different clinical needs, then move to a second module and explain what is the main anatomy and what are the techniques in acquisition in healthcare, in radiology, in order to understand what is the data comes from. Then we move to the module 3 and explain the main part of the course, that is segmentation. And then after segmentation, we start to move into 3D printing and bioprinting. And then we move finally to the 2 last modules that are module 4 and module 5, that is data science of medical image. It's how extract new data from this medical image. And we explain the student how to process and post-process these images in order to quantify, and at the end, how to have radiomics, obtain radiomics from this image.
This course is made thanks to different partners from different parts of Europe, also companies like Philips, but also Heidelberg Institute in Germany, Riga Standard University, Naples, and also universities, technical universities like UPC and others. And it's an 8-week transversal blended training with very needs-driven cases from the clinical field. The target learners that we have are clinicians, surgeons, radiologists, and engineers that will work together. And this course have also ambassadors. So hospitals and universities around the world, for example, in Latin America or in the center of Europe, that are reference hosting sites for the program. For example, we did this course in 5 sites: Portugal, Spain, Germany, Italy, and also in Latin America. And we are focusing on looking for new hospitals and universities that wanted to be ambassadors of this course. Now it's a course that is recognized with European recognized credits from the UPC, Universitat Polytechnic of Catalonia, and other universities. Also from the academics, medicine academics. And we are looking now on creating an international master for 2022 with new partners. And with this year's, what we've done is train 120 students from 5 different editions and 20 different nationalities.
Let's see some examples. These are examples of students that from this edition in 2020, and just the day after they finish the course. And there are 3 examples of how the students are able to print themselves maxillofacial surgery, how the students could plan a virtual reality surgery of an abdominal tumor, and at the end you can see how the students are able to design and to extract features from our arteriovenous malformation of the brain, and how they prepare a biomodel, a vascular biomodel printed, but also with the features of differentiating, for example, what are arteries and what are veins. Moreover, they are able also to extract features and using AI and radiomics. And this is an example of one student from this edition too, and using open source programs, softwares. He was also able, and he understand how to extract a radiomic feature from an arteriovenous malformation. And these are the numeric, the quantitative results from the study. And some examples also from 1 year ago, from the students of 1 year ago, the 19th edition. You can see how the students 1 year after they improve the skills, so that we have an alumni in LinkedIn, and thanks to sharing cases and experiences, they were able to create in Uruguay a 3D lab in the University of Uruguay. And this is the example of the maxillofacial that you see the face of the child. That we have also experience with orthopedics, a traumatologist who designed himself the cutting guides in order to plan a surgery. And also we have experience in AI with Dr. Kandans Makeda, and he's working in Israel, and he's also planning and sharing in some Python projects in order to extract also characteristics and features from medical image.
So to sum up, and that's our final message, we think that there's a gap in medicine that it's being covered thanks to new technologies between the engineering, knowledge, and the medical field. And with this program and with the work that we are doing, we are trying to close this gap to make solutions for the patient affordable and reality. And one example of that is how 3D printing and AI helped in this pandemic, in COVID, with different examples that you can see in the screen. So with that, thank you very much. We are very happy, and we hope it was inspiring and to share more experience.
Thank you.
Thank you, doctors. Thank you very much for this intriguing presentation on integrating data sciences, then fused deposition modeling, which is basically 3D printing and radiology, and using AI in the entire process. Just as a few questions from taking certain questions from all the panel members, I just wanted to know how robotics in intricate neurological surgeries and AI in diagnosis would complement each other and achieve excellence in clinical care in coming days.
Good and relevant question. Let me share again my screen to show you one last image that we did not show, but we think it's relevant. I don't know if you can see it.
Yeah.
We think that robotics, artificial intelligence, and all these technologies of 3D planning will come to complement the work of clinicians at the face front at the surgeries. What we are doing is taking the 3D planning and the artificial intelligence quantification, and what you can see in the image is a real example of what we are doing in our hospital today. We are bringing what we are doing before the surgery to plan the surgery into the operating room with the objective of being sure that what we've planned is exactly what is happening and that there's no errors to minimize risks for the patient. In that case, you can see how doctors are trying to see if the planning that they did and the results of the surgery are equal, and in that case, if there's any deviation from what they planned before, to look for the best for the patient. We envision a future in which this mix between engineers, physicians, and these new technologies become more and more a reality and help improve safety, security, and clinical outcomes.
Sure. Thank you, doctor. Thank you. Another question, relevant question is how research and AI is going in direction where mathematical algorithms can predict biomarkers from basic diagnostics like ECG rather than MRI. So is there any research which is going on? So instead of looking at the MRI images, one can just look at the ECG images and identify biomarkers and predict on outcomes in case of cardiac sciences.
according to the images, not just MRI, but the other images, this is a fast and growth field. That means that we are using more and more AI algorithms, and not just those algorithms that we did as a research from the perspective of collaboration with universities, but also algorithms implemented by the brands. That means the main companies, let's see, Philips, Siemens, Agfa, those companies are integrating AI algorithms in the diagnostic pathway. That means that in every modality, we have several AI algorithms.
Okay.
What is the limitation? When you prepare an algorithm, you need to know that in fact, at least in healthcare, there is two limitations. The first one is the algorithm is mainly prepared for a specific disease. That means if the AI algorithm is prepared in CT in order to detect aneurysms of the aorta, this algorithm just works for this problem. And the second one is you need to test in your own population. And we have the experience that some algorithms that in a Asian population, those that I presented from chest X-ray, that has a lot of sensitivity. They come from China, they come from Wuhan. Then when they arrive to Barcelona and in Spain, the sensitivity goes down fast. So we need to train with different populations, and in this case, the health population, the healthcare population that you are talking, you need to train your own algorithms. And at least from image, these are the two main ideas that we need to always keep in mind.
Sure, Doc. There's one more question from one of our participants, one Mr. Stanley Kurian. He says, how this 3D printing will help the hospital in cost cutting?
In cost cutting, really good question. What we are seeing, and we are having some studies on that, we are comparing the time that we spend, the more time that we spend before the surgery, because preparing all this 3D printing and anatomy, and the time that we have in the surgery. And what we see is that for those specialties that are really protocolized and that are using, for example, surgical tools that can be used and printed and used in the surgical theater, we see an increase in hours of preparation, but a decrease up to a 40% of the time of surgery. That means that the costs of the surgery are much higher. The amount of time that the patient is in the surgery, it's much higher. And the security then it's improved, and the outcomes are improved. And in terms of economic and cost, you have a reduction on cost thanks to this protocolization and reduction on time of surgery. But not only that, you can, on the time you win, you can allocate another surgery. And that's also a way of having some cost reduction.
Perfect. Excellent. Thank you very much, Dr. Joseph, Mr. Arnav. So it's been a wonderful session we had. Thank you. We will take any other questions if it is there for you. Right now we have this much of questions. We'll move to on our second presentation of the day. Thank you very much once again.
Thank you.
Thank you very much. It was a pleasure.
Yeah. So we have our second presentation of today, and that's by Dr. Ranjit Das. He is assistant professor at Enupaya Research Center. Enupaya University is a deemed university at Mangalore. He's a population genetist by training and has expertise in biostatistics, evolutionary bioinformatics, and molecular evolution. He had his undergraduate degree in zoology from Kolkata, and also master's in biotechnology from University of Kolkata. So he's also a master's in zoology from Southern Illinois University, Carbondale, and also followed by a PhD in biological sciences from Duquesne University, Pittsburgh, USA. Post completion of his PhD, he moved to UK, where he did his postdoctoral thesis in University of Sheffield in biostatistics and bioinformatics. He joined Enupaya Research Center in 2019, and his aim is to set up a research group in population genetics and evolution bioinformatics. So I would welcome Dr. Ranjit Das. The stage is yours, and we are very much excited to hear at your presentation, sir. Thank you.
Thanks for the introduction. Is my slide visible? Hello?
It's visible, sir. It's visible, sir.
Okay. Good afternoon, everyone. It's almost good evening. So my talk is not going to be so much in artificial intelligence or data science as the traditional term. So what I'm going to talk about is how big data, big genomic data can be used. The big genomic data can be used for personalized medicine and personalized healthcare. So the era currently we are in can be considered as the era of genomic healthcare and personalized medicine. As those who are from India may be aware of that Jyotish, the astrologers are very popular in India, and they make something called Janampatri. So it is time to move away from Janampatri and move towards a new era of Genompatri. So you can predict the disease or the traits that you may have in the future based on your genomic information. This is a field that is emerging for last 4 and 5 years, and I'm pretty sure in the next 10-15 years, this is going to replace a lot of personalized medicine field, and this is going to be integrated with AI, and this is going to be the future of healthcare. So let's see how it. So before going any further, let's see those who are not aware of biology so much. So our genome is basically consists of 3 billion letters written in 4 chemical bases: A, T, G, C, adenine, guanine, cytosine, and thymine. And together they provide a coherent set of instruction that dictates our personal attributes and it determine how our body functions, basically everything. So how big are these letters? So if you speak 1 letter of DNA per second and go on doing it for 24 hours, it will take you 100 years to complete the 3 billion letters that we have. So that is the huge amount of data is stored in our own cell in a packaged fashion. So the way this personalized genomic healthcare will work is to decode this information and to predict how they can regulate our body functions as well as our healthcare. So to be really honest, all individuals in the planet, all humans are 99.9% identical. We are so much identical because humans underwent something called a population bottleneck way back in Ice Age. As a result, all humans have gone through something called a single founder effect. As a result, we are very identical. We are only different from each other by 0.1%. And that 0.1% makes us unique and makes us ourselves. So among this 0.1%, most of this is accounted for something called single nucleotide polymorphism or SNPs. These are basically a single nucleotide change in our DNA sequence, and as you can see, it may get replaced with another letter, and that may actually cause a lot of changes in terms of the traits as well as the healthcare. We are interested in healthcare, that's what I'm stressing on. Healthcare is not only limited to healthcare, it can be any trait. There are around 14 million SNPs that are distributed throughout our genome, and that can contribute large amount of human variation. This is the only one. There are other variations. This is the largest one. So as you can see, so those who are aware about Genie from Aladdin, so I'm making a comparison with Genie. So basically our Genie is basically the new Genie. So if you can ask our Genie properly, we can have a lot of information about our risk of different disorders like cardiovascular disorders, hypertension, diabetes, cancers. Not only it doesn't end here, it can go about drug abuse, nicotine abuse, alcoholism, and you name it. So this can actually help, this understanding can actually help to form the foundation of a personalized genetic testing, and which can also be make the foundation for the personalized healthcare and personalized medicine. So as the topic of this webinar, prevention is better than cure, prevention starts from here. So if you know what are your possibilities, then you may go on checking or may go to the doctors multiple times, or you may actually prevent before the disease actually appears. So I always would ask to know your gene first, and then you can probably avoid a whole lot of diseases from coming in the future. So the big data traditionally, when I'm talking about biology, comes from different databases. So one of the biggest databases is 1000 Genome Project, which is very well known. Besides that, there is human HGDP project, Human Genome Diversity Project. There's Dr. David Reich's lab also has a large database. Then the Genome Project from National Geographic. Then is Genome Asia, which is also very popular right now. Genome India, when it is going to finish, it will have 10,000 Indian genome, maybe more, but it will take some time. But once we have this Indian specific genome sequence, then we'll have a hell lot of information about our healthcare, and that can actually help in our healthcare regime a lot in the future. So there are different diseases that has predisposition towards towards diseases. Here, I am not talking about genetic disease. Remember, these are multifactorial disorders. These are not genetic disorders. These are multifactorial disorders which has a genetic component. And when we talk about multifactorial disorder, it is basically a result of the interaction between the gene and environment. So we already may have a predisposition for these disorders, but it still needs an environmental trigger. In the absence of the trigger, these disorders may or may not appear. Give an example. Suppose I have certain mutations, certain polymorphisms for lung cancer, but I never smoke a cigarette. There is a possibility that those lung cancer mutations may not appear in the form of lung cancer in my life. Having said that, if I am experienced with passive smoking, I'm not actively smoking, but experienced with passive smoking, those mutations, those polymorphisms can still be triggered and may cause lung cancer. So not only individual variation, there is a distinct population-specific variations of these disorders. So there are, if you may, I'm not going to detail, this is my main research topic. I look at different population variation of the diseases. So there are different populations across the globe, and some populations are more prone to certain disorders like compared to others. If you have interest, you can go to the ECNH website, and that will give you the details of how population-specific variation is also playing a role alongside individual variation in disease susceptibility. So if you have to understand population-specific variation, you have to understand our origin. You have to understand our roots, which is given by our ancestry. Ancestry is not the ethnic group, ancestry is not the race, but it is the intrinsic individual population-specific variation in an individual that is basically an admixtured component of different geographical areas. Here I'm showing one lady. She is an European by her phenotype, by her appearance, but she also has some Asian components, South Asian component, Chinese component, which is not visible through our phenotypes. But if you genotype, you will find this kind of variation in her genome. So why it is important? If there is some propensity of certain disorder in Chinese or South Asian population, since she already has those variations, she may also be susceptible to disorder alongside those European specific susceptibilities. So in order to understand your disease regime in genomic propensity, you not only need to know the individual variation, you also need to know your ancestry specific variation. We recently finished one study. So what we are looking at, the population-specific variation of SLC6A4, which is an important gene, plays an important role in the neurophysiological development. And what we have found that there is a population-specific natural selection operating on this gene. And as you can see, this green line, these are East Asians, which is distinctly above the other three populations, which are Native American, East Asians, Native American, European, South Asians. So this population is distinctly under the natural selection for this gene. And as a consequence, we have found in the empirical data that East Asians significantly face higher problem in the neurophysiological development compared to the other three populations. As you can see, this is the genomic makeup of this East Asian for this gene is very different from the other three, which clearly indicates that there is an ancestry-specific, population-specific component for this neurophysiological associated gene SLC6A4. The problem with India is Indians cannot be grouped in certain populations, because although 23andMe gave it a trial to group Indian populations, India is much more complicated to group in these 4 pockets. So recently we have found that India is much more diverse. So each color represents one population group. As you can see, there's so many colors. And only from South India, we have found at least 6 ancestral components. So at least 6 founder populations are there only in South India. You are not even going to the North India. So India is so diverse that we see different population-specific variation in disease susceptibility specific to India. So we are currently doing one study to see how neurophysiological development varies among Indian populations. We assessed around 1662 South Asian genomes, which includes Indians, Pakistanis, and Bangladeshis. And we used 384 SNPs or polymorphisms, that is neurological and psychological disorder. We found that, like before, the Northeast population, which has high amount of East Asian genome, like Makar, Sherpa, and the Northeast populations, have a higher propensity to have these neurophysiological disorders. But story doesn't end here. What we have found is 7 out of 10 genomes which have the disease allele is found in South India. And the story actually matches with the empirical data. What we have found is recently, in December 10, this very recent article in Telangana Today, they have found that there is a high prevalence of depressive disorders, is one of the neurophysiological disorders, in Tamil Nadu, Canada, Goa, and Telangana, Andhra Pradesh, and Odisha, which clearly indicates there is a genetic component that varies among populations in India that has some association with depression as well as other neurophysiological development. Not only neurophysiological development, what I have found is there is a significant association of our genetic ancestry with COVID-19. Since every talk or webinar right now focuses on COVID-19, so I will give you some glimpse of it. So there is a population-specific variation as well as the individual-specific variation of COVID-19. So more and more big data as comes for COVID-19, we'll find out more and more. So, but it's a preliminary statement. We have distinctly found that East Asians, the Northeast, as well as the Chinese, Japanese component, they are less susceptible to COVID-19 compared to the populations from Europe, as well as from India, Northwest populations. So there is population as well as individual variation in COVID-19. But the story doesn't end here. The individual variation can also give you a lot of understanding about your addiction to cocaine or heroin, or whether we can metabolize certain things. For example, caffeine. Do we prefer caffeine? Would you like caffeine? Can you become an athlete genetically? Do you have that athleticism genetic component in your gene? This all can have a genetic component. It is not the only genetic component. You have to have environmental trigger, but still genetic plays an important role here. Finally, the drug metabolism also varies from population to population. And that's why we said the precision medicine is coming based on genomic healthcare. Because as long as you can see, nowadays, single drug is prescribed for all different populations. But since their genetic makeup is different from each other, they will not be helpful for each other. So first we have to know the population specific as well as individual specific genetic makeup. Then only we can prescribe the dosage as well as the amount as well as the type of medicine that we prescribe for certain disorders. So it has been already shown that this is one study I have cited in 2013 way back in, that there are some populations which are more prone to differential responses against certain drugs. For example, East Asians and Europeans are the two big players who shows big variation in response to certain drugs. I'm showing one example of the drug fluoxetine, which shows variation, which is antidepressant, and shows variation from North Indian and South Indian. The reason is, as I already mentioned, South Indians have a higher propensity of depression, and that's why maybe the reaction, the response to fluoxetine is not the same between the North Indian and the South Indians. Finally, I would end here. So we have a startup called Genome Mapster. We can help, you can register yourself with our startup, and we can just collect your saliva sample, and we will analyze your genetic makeup, and we will email you your health report and whatever you want, your ancestral makeup. And if you are interested about knowing yourself and knowing your roots, you could just email me and we can take from there. With that, I'll take any question. Thank you.
Thank you, Doctor. Thank you very much for that beautiful webinar on genomes. So basically, my takeaway was population specific and ancestry specific genome diversity, what we have. Disease variations on population through genome, and also drug metabolism being population and genetic specific. And that's were the real takeaways for us, I think, over this. Yeah. Yeah. Just one question from all of us is that one, Doctor, how do you see the convergence of large data sets in genome mapping and artificial intelligence in coming days?
It is actually already happening. So the data that I collect are all basically, these are the big data and the genome map data. The thing that has not happened yet is the merging of AI with this, but that will take some time, because first we need to understand we are still in a very nascent stage in understanding the genomic healthcare. Once maybe we understand this better, then like our previous speaker showed in case of the 3D imaging and all, but to go to that stage in this one will take at least 10 years, 5 to 10 years, but it will happen eventually. It takes some time from now.
Thank you, Doc. I think at this point of time, we have these questions. As the questions proceeds, probably we will have other further questions from the participants during the end of this webinar. Thank you very much, Doc, for this respective talk. Our next, we'll move on to the next talk in our webinar, the penultimate one, not the last one, the one before the last. I'm very, very happy and glad to introduce to you all Dr. M. Prakash. He's an assistant professor in SRM University in biostatistics. Is a healthcare professional with 8 years of experience, having proficiency of working with large data sets. He has undergone theoretical and practical activities in streams of public health, and he is proficient in using statistical softwares like SPSS, R, SAS, and his experience has been in gaining knowledge in research and data management, monitoring and evaluating analysis, project management, report writing, and practical skills in conducting training and capacity building. We welcome him, and his talk will be on public healthcare infrastructure, the big data and its impact on the public health, and the challenges and the mitigation strategies what we would be having. So I would welcome Dr. M. Prakash. Sir, the stage is all yours.
Thank you, Vikram. Yeah, I'm happy to share my experience basically here as a health data scientist now. So I think I just want to say good evening to all, and what we heard so far is like really good, and so I'm going to talk about data science and public health. So the most of the interventions or most of the innovations which came recently in health, whatever came in health now is mostly in private, or in the sense like predicting the health outcomes, So for me, the AI in healthcare, there has been exponential growth. Like artificial intelligence is the word which we are hearing now everywhere, and it is in various domains, which is helping us to Can you hear me? Can you hear me? Hello.
Yeah, we can hear you, sir. We can hear you. Some background noise we have, but or else you are audible. Thank you, sir.
Okay. So the AI is the word which we used to hear very commonly nowadays, and it is expanded in various domains. But especially in healthcare, it is changing the face of completely changing the healthcare delivery, especially. On the global AI in healthcare market is expected to grow very drastically, which is like now expecting like prediction is like 5 billion in 2020 now, and which is going to be like 50 billion by 2026. But this is going to what it is going to bring in future is like there will be an imbalance between the health workforce and the patients, because the trend in the health, in the sense like non-communicable disease, which is growing very high, and which is very difficult to control. So there will be a definite imbalance between health workforce and the patient. Okay, and if you see in the recent like the innovations in medical and biological engineering has started earlier, like 1950s we started with like ECG, antibiotics, like that. So then it slowly emerges, like there are a lot of medical innovations which grows, and now we are at doing, like because of thanks to the AI, like now we are into robotic surgery, and we are now ready to edit the genomic part. I think that is what we came up with a Nobel Prize for this year. It is given to those who have done a very good job and fantastic, and which is unexpected, and now they are working with gene editing. So that's the level where we are now in artificial intelligence. So there are more smart gadgets which is coming, evolving now. Like if you see, like everything is handy. Like you can see, you can every day you can monitor your own health, right? Like ECG is very handy now. Like previously there used to be multiple wires, and you have to go to hospitals, and there is a more cost involved, right? But now it is handy, like you can check your own health every day, which will prevent you. I think the topic we have for us today is like predictive analysis is better than cure. So those smart gadgets now is helping us to predict our future to some extent. Yeah, it is really good. So like now ECG and even the ultrasound has came very handy. So that's the way, like we have to thank AI, which is going to predict our whole future. But if you was looking at whatever we have seen so far, is like it's like a private, or like most of the like business model. But while coming to the service provider, there are more applications developed, but still there is a problem of implementation. If you see, these are the big data sources available for a public health, like starting from the hospitals, consumers, and where they are purchasing, like pharmacy. There are more electronic EHR which came in mid of 1970s or 80s, but still we are struggling to implement electronic health records, which is not exhaustive. If all are there, but still there are a lot of data source available, but the way we are analyzing or used, the data which we use is very much limited. If we can able to use those data, and if we can come up with a very good analytics, I think we can able to prevent multiple diseases, like huge diseases, like especially like COVID. If we should have used all these data sources efficiently, we might have stopped the spread of COVID. Okay, so I'm just taking one example of what we are using now is like public health surveillance system, which is existing in India. If you see, basically the data which we are getting now, this is the way we are collecting data from the public health department. Okay, and the data for this surveillance, like this is surveillance communicable disease, we are collecting only from government departments. The reporting from private is very minimal. Okay, so whatever we are collecting is not the real time. That is another point. So if we can able to get it in a real time, then we can able to predict a much many more diseases, and we can able to prevent those diseases. Okay, and for big data, like especially for the surveillance, as of now we are using only hospital based records, which is again government, and labs, which is again the government labs. So only with these two sources, the government is struggling to predict or identify the diseases through routine regularly. But whereas if we can able to use artificial intelligence or machine learning, like we can get data from pharmacy and electronic health records if it is implemented very well, and especially from privates which they are already using. If we can able to use that, and we have multiple disease registries from the government, like TB, HIV, so like those kind of data, like health workers, they are collecting data regularly from the field, like community level. And finally, like social media, where now we are getting huge data from the social media, and like everybody will start reporting like, okay, I got a fever. There is one COVID case nearby my home. Those kind of data, if we can able to use or tap it efficiently using the big data or artificial intelligence, we can able to predict as well as prevent lot of diseases. So especially for this social media, so whatever data we are using so far in service delivery, those are structured data. But whereas in social media we have unstructured data where we have a huge scope to predict the disease, for which like machine learning technique like natural language NLP can help to identify the pattern recognition and some of like visual perception which will help in decision making. So machine learning is one of the most exciting areas for development of computational approaches to automatically make sense of the data, and so that we can able to prevent lot of diseases, as well as like the government can take immediate steps for preventing those diseases. Like, so recently we have heard some deaths because of unusual diarrhea or something like that from Andhra. So if we have efficient system like using artificial intelligence, then we should have able to prevent before it goes viral. So if you see this, this is one of an example where we used simple machine learning algorithm to identify the fever cases from daily reporting of government system. So with this we can able to identify very few outbreaks, but if we can able to use social media, then we should have identify more of outbreaks, which will help us to prevent the outbreaks immediately. So in taking another case like public health program like TB, which is like tuberculosis, we have data from only public health departments, and so again the source can be, now as of now it is only from the government health department and hospital, but there are some labs which can report, and pharmacy. So if we want to estimate the true prevalence of TB, we can't rely only on hospitals, because as TB is considered as a stigmatized disease, we have to rely on pharmacy and some other database, so which can help us to identify the true prevalence of the disease, and we can able to prevent the spreading of the disease, and we can treat the patients immediately. As we are moving towards extreme drug resistant TB, and if we are not going to get the data from multiple sources, and if we cannot able to use that, then it is the failure. And I think artificial intelligence can help to solve this problem. Okay, the future of the problem, the future of the public health, if we can able to use the artificial intelligence and machine learning effectively, then the future will be like the most of the public health agencies will spend most of the time not in gathering the data, rather they can help or monitor the health of the population, and they can focus their time and energy on analysis and prevention of the disease. So but the potential challenge for the health or the private the providers, which is the service providers, will be the development cost, because as I said in the first slide, the expenditure or the allocation of the fund is like only 2% of the GDP, not 1.2% of the GDP is given for the health and the artificial intelligence, especially in India or developing countries. And the other challenge will be on the privacy and security of the data, and the data exchange between interoperability of the data between the departments, which is a very big task which we have to solve. And sure, this is possible with our health infrastructures, and which we have to think of. And finally the regulations, which we have to change to the current trend of AI, so that a lot can be done. So there are some gaps which needs to be addressed immediately, so that all can be done, like the AI can be useful. Mainly, like there are multiple apps developed, but only thing is like the implementation is the where we are failing, in the sense like implementation is like we may not able to achieve fully. So whatever we are doing that, so we are doing that for individual, like when we are coming to the service provider level. So now the global context is like looking at the sustainability. The sustainability is can be achieved only if we can we have to look at the whole rather than looking only at the individual perspective. So that is what like public health we can able to achieve. It is not with the individual. So data scientists who we are going to work hereafter should algorithm developers must be careful. So since health is not an individual perspective, it is like it is multiple factors involved, and different regions might have unique physiologies, and environmental factors will influence the disease. As it is said by Ranajit Das, like individual patient care is based on genome as well as the ethnicity, and it is wide. So when we are developing an algorithm for as a data scientist, we have to look into all the aspects, not only minimal. We should use the big data basically. That's from my point. The takeaway from the whole session is like whatever we are trying to implement, I think the importance of the data to be understood by the clinicians, because if the EHR is used by the physicians, then most of the disease can be preventable, in the sense like they can take immediate measure, and expenditure on health informatics to be increased, so that and acceptance of information system is a need. See, especially like if we want to use as a clinician, if I want to use an electronic health record, which everybody will feel that okay, which is a huge task for me when I am looking at a 300 patient number of patient, if it is increasing, I can't use EHR because it is going to be a burden. But for this, if this to be handled, when the student is trained in a college, they have to start implementing there. So that's the only way EHR can be a regular part of the work rather than it is perceived as a burden. Thank you. I think I can stop here.
Thank you, Doc. Thank you very much. I think the major takeaways would have been from this session of yours was big data and its importance in public health. And of course, the specific focus, what you said about health informatics being part of the curriculum, and also it should have well-built data mining tools around it so that those can be extracted very well for algorithm building and model building to involve these things in public healthcare management. Thank you very much. We have few questions, one from a participant, and later on I have one question. I will just take first question from a participant called Mr. Nasir. He asked, what are some commonly used statistical concepts in healthcare analytics?
So mostly here, for like there are two things. Like one, if you are looking at service provider level, mostly it is a classification techniques where they will use like what kind of disease is common. If like uh, classification techniques is the one which they will use mostly, like factor analysis and prediction is very few. Prediction in the sense like logistic regression analysis or decision tree. Decision tree is a cart, or decision tree is the one statistical tool which is most commonly used for predicting as well as classifying what kind of disease is that and where they will, based on already known factors.
That's thank you, sir. The other question from my side is, Doctor, is we spoke about the challenges in integrating big data in public health system. My question is, what could be the mitigation strategy to overcome these challenges in order to achieve the larger social good?
Yeah, good question. In the sense, like actually, here to handle a big data, if I'm a physician, I may not be able to work with programming, and I'm already scared because no, like our education system is like built on okay. If I'm going to be a doctor, I will mostly work with biology. I may not know about completely about the data or statistical part. So but we can't do anything with that. But the multidisciplinary approach, so which will help to mitigate that. And another one is like open-mindedness, like to collaborate. I think that's what needed as of now, so that that a doctor should not think that okay, data scientist is just he knows only the data. So unless we are open to that, I think if we are ready, I think now it is open. Like I think most of the students, the professionals are open to collaborate, and if we can collaborate efficiently, I think that is going to great. And investment, especially the funding by private and publics, if it is increasing, we can do a lot.
One final last question, Doc. What do you think is the impact of artificial intelligence on telemedicine and teleradiology initiatives, which have been excellently taken up in coming days by both private and government sectors?
Yeah. So the like both have very much important, because no, like as of now the current trend is one is like for private, public is immaterial, but the thing is like who is going to get benefit out of it. One is like rich or poor. If we are looking at the poor people who are living at the remote villages, though there is a connectivity, but reaching specialists, especially nowadays, is very difficult. But artificial intelligence is going to help them in the sense like maybe in future the robotic surgery, instead of people coming to a tertiary care, tertiary care hospital, which is located at the city level, if robotic surgery is possible, that can help a poor person who is sitting there in a remote village, and the cost will be reduced. So I think it matters. I think because that is why telemedicine is getting importance now. Only thing is like the thrust, like those who are sitting at the remote, they will think that okay, if I look at the doctor, if a doctor is touching me and he perceives, then I will get relieved. So that I think it has to come out, unless it is going to help a lot for a poor people especially, and it is going to cut down the cost, and it is going to cut down the time, everything. So it is going to be the future.
Sure. Thank you, Doc. It was a wonderful session of yours. There was one question from one of our participants. I think that actually matched with the answer what you said through. As of now, we have only these many questions. The more it comes, we can take it at the end of this webinar. Thank you very much for this interviewing session, sir. We'll now move to our panel discussion. Our last presentation. I would like to introduce to all of you Dr. Eliza. She is trained in epidemiology. In addition to her economic evaluation research, she has responsibilities in teaching and mentoring masters in public health institutes and in IIPHS, basically Indian Institute of Public Health. She has interest in ethics in human research and have been mentored by Professor Richard Cash. Her research has been in experience in chronic diseases epidemiology and evidence-based policy implementation, with special interest in women's cancers. She has been awarded the Early Career Fellowship in Public Health by Wellcome Trust, Department of Biotechnology, for working on epidemiology of gallbladder cancer. I would give the floor to Dr. Eliza. She would be speaking more on, once again, on public health and epidemiology, and how do we use data sciences in public health. So the session is yours, Doctor.
Okay, thank you, Vikram, for a wonderful introduction. And you don't need to call me doctor. Okay, anyways,
sure.
Let me share the screen. Let me share the screen. Yeah, I hope it's visible, and I'll just put it on full screen. So I'll be talking more about the predictive analysis and its potential and challenges in the public health decision making, very much in continuation to what Dr. Prakash has been talking in his session. So, but before I start, I would really like to talk about like what does a layman's understanding is, because I would consider myself as a layman when it comes to data sciences. So for me, it's actually an elephant in the room at a time. But still, like, we understand this as the data sciences or the predictive analysis as something data-driven analysis, which confirms the association between important factors, which are based on the relationships between variables obtained from multiple data sources for predicting outcomes. And its scope in the decision making is that it actually we can make some efficient and effective decisions, especially in the public health, because the evidences which are produced through these kind of tools are mostly based on comprehensive and multiple data sources. They are less biased, and the analysis is controlled because we are actually teaching the model to get what we want. And many times, many of these models, such as the decision tree model, the Markov's model, they actually help us to come up with an extremely important tool that is called cost-effective analysis, because in the government, when we actually make the decision, everything comes down to the amount of money that is left, the amount of resources that we can spend. And therefore, it actually helps us in planning in advance. Like we can predict, like, how do we plan our resources accordingly, and helps us strategize. Like this man, whether to go back to sleep or sleep in the office. Okay, so I'll use an example that we did to estimate the burden of cancer for state level using global burden of disease methods, because cancer is, we used global burden of disease methods to estimate the state level burden for 333 diseases, but I'm using cancer as an example because number one, it's my research interest, and also it is the second most non-communicable disease causing mortality across the world. And in the low middle income countries, because of low awareness and delayed diagnosis and also poor access to the affordable care, the problem aggravates. And plus, there is an absence of systematic and comprehensive understanding of the actual magnitude and the time trends for each state at population level, which is actually an important thing we need when we do the decision making, because health being a state subject, it comes down to the state to devise strategies. Therefore, we estimated mortality, disability adjusted life years, that is an aggregate for mortality and non-ratio. We the mortality estimate using years of life lost, and the non-fatal indicator is a years lived with disability, and then we sum it up and we get DALI. And the third, we also estimated the mortality is to incidence ratio at population level, because this ratio tells us about the efficacy of the health system. Like if the mortality should not be higher than incidence. Incidence means the new cases. So I'll be here quickly go through the model. I will not bore the audience with the details of it. So here first part is the mortality estimation, that is actually the YLL, years of life lost. So for which we had data, incidence and mortality data from the cancer registers, which were mapped for age sex split using the standards from the international cancer databases, and also to the levels of cancer that are defined by the GBB methods for their steps, that is the sites of cancer like oral, mouth, tongue, pharynx, etc. Then the redistribution of the codes were done. That is, we also have something called the garbage codes, which are essentially not the underlying cause of death, but the immediate cause of death. Example, heart failure. Heart failure can happen in a cancer patient. Heart failure can be the cause of death for any other diseases also. So therefore, a certain proportion of those codes are also redistributed. And finally, when we have the MI ratio, that is the mortality to incidence ratio, they are also applied to the best available incident data available from that location. Now for India, we used this incidence data from the population-based cancer registry because they are the gold standard in our country. Then finally, they were put into the cause of death ensemble model, we call it CODEM. And after correcting for age, sex, location, and for cancer type, example, there are certain errors in the data, example, cervical cancer in men or prostate cancer in females. So this kind of errors were rectified in the correct model. And then we estimated the population level years of life lost. Then comes the second part of the DALI, that is years of the years lived with disability, which is essentially prevalence multiplied by the disability weight. Now prevalence was estimated from the incidence, which came from the registry data, and then the duration was estimated by number one, either the survival data, that is the survival for 10 years, or the time between the diagnosis or death. That is one. And the second, the disability weight were again estimated for two things. One, the sequela. Sequela means whether it is that the phases of cancers, that is whether it's diagnosis, remission, metastasis, or terminal, or the different procedures, example, mastectomy, prostatectomy, stoma, etc. And then we had two type of YLDs for sequela and procedures, and they were combined to find the actual YLDs. I mean, so basically you are multiplying here the survival for prevalence. I mean, you are converting incidence into prevalence, and then you are multiplying the disability weights to get the YLDs. But now, despite doing coming up with these DALIs, and of course it was very much well received by the state governments, there were certain challenges we found in the data. Number one, there are no population-based cancer registry data in the most populous states like Uttar Pradesh, Bihar, Rajasthan. Second, the issue with the mortality data, because hardly 20% of all deaths in the rural area are actually registered. And we all know that is more than half of the population in the country are actually residing in the rural areas. And then whatever mortality data are available, hardly 1/5 of all those are actually ICD coded. So we are actually losing out on the real cause of death. And even if we have the mortality estimates from the cancer registries, we had an issue in those data because they were not adequate enough to actually come up with the estimates for types or site of cancer. So we did not know the type of cancer mortality that caused it, because majority of our patients come at the last stage, and many a times it becomes very difficult for us to actually identify the primary site of the cancer. Therefore, we came up with certain model adjustment. Number one, the states that had at least one population-based cancer registry, the incident data were actually transferred to mortality. So the model was reversed there. And then that was applied to the already modeled MI ratio to come up with the incidence, because again, incidence was our gold standard. Therefore, we did a remodeling there. Second, states without any PVCR, the cause of death data actually came from the sample registration system data, which are actually the verbal autopsy, and that gives the most probable cause of death. That is second. And then anywhere when the data sources were differing significantly from the registry estimates, they were excluded. And for the location which did not have any data, the estimates were actually driven from either the neighboring state estimates and the covariates. So we also use certain covariates, example, the socio-demographic index, the health coverage, the number of hospitals, etc., for determining the possible outcome. Now, saying all this, although despite our best efforts, we tried to come up with the state level estimate for cancer at the population level, at that granularity, still there are certain barriers that usually a data scientist or a predictive analyst find to make his or her voice heard to the decision maker. There is still a gap. First, there are always certain biases and the modeling assumptions, which many a times doesn't agree. Like here, we were supposed to use mortality estimates from the registry data, but it did not agree with our policymakers or those who are in charge, because we know that our mortality data in the registries are not that great. There are also issues like data that was also pointed out by Dr. Prakash in his talk, that we have the issue in sharing data privacy and the transparency, because we really don't know how the data will be used in the modeling. So people are scared to share their data. Then the third, first of all, there is a lack of optimal technical skills. There are not many data scientists working, or there are not many people working in the field of artificial intelligence even now. And those who are there, they're unfortunately little siloed there. Like there is a gap. We don't know what they are doing. Data scientists are working in their cocoons. And the last one, which is a major problem in a country like us, that even if the predictive algorithm is accurate 99%, in a population of 1.5 billion, there will be at least 1.5 million who will be either false positive or false negative. Therefore, that poses a major challenge for the decision maker to come up with it. So despite all our difficulties, this is what creates a barrier in accepting those models to implement in the decision-making process. But if there are problems, there are solutions, of course. So as we know that data mining is the potential future, but when we should also be careful when we actually do the primary data collection. And that's where the focus must also be there, because if there is problem in the primary data, even if with the best tool, we will never get the effective answer. So it's like you feed in erroneous data, you get erroneous answer despite your best tool. So when someone is actually collecting the primary data, the quality must be taken care of. That's where all the focus should come in. Then, of course, the skill development and the capacity building, that has to be there. And the collaborative activities should be encouraged between the stakeholders, those who are actually making the decisions, and the various technical and the skilled personnel. So that's the only way to actually come up with such a wonderful tool that has an immense potential to bring about the evidence-based informed decision. So with this, I thank the Asian Institute of Design for giving me this wonderful opportunity to speak and play my part in trying to bridge the gap between these two worlds that has an immense potential in bringing what is the best for the country like us, that has like huge population, huge data, yet we have our own challenges to bring the better common good. So with this, I thank you once again, and I'll stop sharing screen, and I'm ready to answer questions.
That was an awesome data imputation strategy, what you adopted for missing parameters in your cancer mortality modeling. Wow, it was mind-boggling. With a lot of missing parameters, that was the best imputation strategy. I think that was the best takeaway for me as such. We have a few questions you just to make this thing. I heard the point of your accuracy in terms of model accuracy, but my question to you is, in advent of increased research in applied mathematics and computational engineering, and also interdisciplinary approach between data science and medical sciences, the accuracy and generalization of predictive models are getting sharper day by day. In light of this, is accuracy of models a barrier in predictive analysis?
No, accuracy is never a barrier. But the problem is there are other barriers, like, there are much more basic barriers, as I like to call them. Like the first problem is our huge population size. Even if after all, model is a model, predictive model is a model, it's not God. So even if your model is as accurate as 99.9%, which doesn't usually happen, even if it is so in the ideal solution, still that 1% will at least have me 15 lakhs people. So you tell me, if I'm sitting at the decision making, it makes me think twice. So that is one. And the second problem, which are much greater than accuracy, are the actual data quality that we are feeding into the model. We have like so much of data issue in the ground level that if you're feeding garbage, you will get garbage. That is the major problem. So many a times, despite our best of the tools, we are not able to use many data sources. So when we sit with our data, like so many sources just go away because of their poor quality. And the third thing that I would like to focus here is the great heterogeneity. We are truly nation within nation. What is like true for Bangalore is definitely not applicable for Shillong. What works in Chennai doesn't work in Gujarat. So that is the problem. So in the end, and it is really very difficult to work, have a separate model for every population. Like Dr. Ranjit was talking, like India is such a canvas where like every place has like, we just don't know where we come from. There is no homogeneity in us. So that heterogeneity is a blessing plus a problem. So these are the basic problem rather than your accuracy. Of course, accuracy is never a problem. It is, after all, something is better than nothing. But of course, if these three are also worked on, so probably like, with that accuracy and the generalizability, we can actually work towards a more sustainable solution, as we say, for the better common good, and it might have a more effective and a more efficacious decision making.
The final question is, what has been your experience? How successful it has been, or how varied it is in terms of using predictive models in COVID-19 prediction in India?
Okay. So first of all, I would like to have a small correction. It is not for India. We did it for the state of Meghalaya. So we, in fact, we were requested by the government to come up with a prediction model. We made them 3 models at different time points. First, when the pandemic actually started in March, Then the second one came around in June, July. And the third one was like, so these 2 times we did not have any cases in Meghalaya. Meghalaya was still COVID free. But then the third model came around August, September, when everywhere the cases were going, like it was a peak of pandemic actually, like August, September. So that actually, like, the government listened to all the models, and it actually helped us in strategizing and formulating the guidelines that the government was following, because it gave us the number of cases that were expected in the coming months. It also told us, like, given the resources that were available in the state, example, the number of ventilators, the hospital bed, how the state could prepare. And that's why it actually helped us in preparing the anti-COVID preparedness plan. So, and they were again requested by the government. So it is, despite all the siloing and despite all the gap, it is not that government is not open to it, but provided we also understand the challenges in it, because it is ultimately a model and there is a heterogeneity and the quality of the data that gets fed into it. So, yeah.
Super. Thanks, Doc.
Thank you.
I think with all these things, we have come to the end of this very, very knowledgeable webinar. In fact, for me, all the 4 presentations was rocking everything. So the challenges in genome data, the challenges in public health, the what goes beyond, the models goes beyond the public health, the huge issues of data mining, the huge issues of what is the heterogeneity, what we have. And of course, as the way the collaborativeness between robotics, the 3D printing, and the AI in radiology, and then predicting in terms of radiomics, I think we have seen the entire spectrum of AI being used in healthcare. I'm really this. I thank Asian Institute of Design and their entire staff in making this webinar so intriguing, bringing the best people over here and giving this respective knowledge to all of us. We have, as of now, no questions from the participants. There's one specific question to Dr. Ranjit Das. His question was basically from Stanley Kurian. It was from, how can we establish a branch of preventive medicine department in an hospital based on genome predictions? So that was his question. So this question is to you, Doc.
Hi, nice question. That is actually the idea. But for that, we need the hospitals to come up and to be open about the genomic information of the patients. So there are 2 ways to do it. Either the doctors can also prescribe the patients for the genomic testing or genetic testing, or the people in general needs to be much more aware that this kind of things exist. That even if you are not sick or you are not ill, that does not mean that you may still have the disease in the future. So knowledge is power. So prevention, as mentioned, prevention is always better than cure. So as you know about your mutations, know about your polymorphism, then it can actually save you in the future. So hospitals need to be more proactive, the cost needs to be down, and people in general should be made aware. Then only these things will be helpful in the future.
Thank you for that answer, Doc. I think it has answered our questions, most of our questions. I hope so. I would once again thank all the panelists, all the well-versed panelists to be part of this respective webinar. Thank you very much on behalf of Asian Institute of Design and on behalf of all the participants and attendants of this webinar. We thank you all. It's been a really knowledgeable session. I think we had an excellent 1.5 hours of our day. I think the most productive part of our day was today between 4 o'clock to 5:34 p.m. as I see. So thank you very much. I think we can end this. If we have any questions from anyone, it can be through chat box or between the panelists. It can be now over here, or we can end this session.
I actually asked one question I actually asked one question in the chat box. Can you please forward that question to her?
What was that question?
It's in the chat box. Is it visible?
genome information in your predictive models.
Yeah.
So actually, that I think this is a question to Dr. Eliza, I think. But the thing is, like for predictive models using genomic.
That will convert to Dr.
Yeah.
To Dr. Datta actually.
Yeah. Sorry.
Yeah.
Okay. Sorry,
Yeah.
I couldn't get it.
Yeah. The question was using genomic data in your predictive models. Dr. Ranjit Das' question was, how do you try to use genomic data in your predictive models?
Which model are you talking about? Because we spoke about two diseases.
So
Are you talking about the cancer or are you talking about the COVID?
Cancer, COVID, either. So when you are, so especially the question was for COVID. So when you are making these predictive models, whatever, in Meghalaya, whatever, but do you have tried to include the genomic information when you are trying the prediction?
No.
Because there is
Genome of the virus, or you're talking about the
level and
population
population level?
Which genome again? Sorry, you have to be a little
Humans,
specific to me.
not the virus.
Okay, because we did consider the genomes that were circulating, of course. But when it comes to the population level genomic data, including in the predictive modeling, there are certain issues that we always talk about. Because first, the thing that we are talking about is the expression of the genes. Just because you have that single nucleotide polymorphism doesn't mean that you will also have that disease, because there are other interactions going on, like the gene environmental
Absolutely
interaction is coming up big time, the metabolomics are coming up big time, and we really don't have that data. Like the GWAS studies, that hardly has any data, right? Like hardly 1 or 2 SNPs are getting identified, and then we lack the other determinants which are so important: epidemiological data, the environmental exposure data. Unless we have that interaction data in our place, we really cannot use that in our predictive modeling. It becomes like too much to handle. So that's why we did not use, or till now we did not use any genomics data. Yeah. But yeah, I understand your point, and that is one of my
that's why my question is.
That's my work also, actually. Like I'm working on the gene environment interaction to come up with the risk of gall cancer in people in different population groups in the country, and that's what it comes from. So that the next step could be like coming to a prediction.
Yeah, it's true that there are other components, but still. Because now it has been for COVID-19 specifically, there are several SNPs have already been identified. So at least those SNPs can be tested in those individuals, right? Because there are now
but
around
SNPs,
4,500 people have been sequenced. They can be tested.
Yes, Dr. Das. Yeah, of course, the SNPs can be tested, but only if we know how those SNPs are actually expressing in presence of external factors. Because just because I have the SNP doesn't mean that it will express. So that is the catch there. And right now we don't have that data.
No, absolutely
but
not.
Of course.
Absolutely not.
So yeah, so till we get that data, we are like getting a little scared. We don't have the data. How can we put it? Only SNPs will not give us the data. We have to teach the model, but yeah, not in this model, because the government was not interested in that. Government was more interested in how many cases do we expect, and given the resources we had. So we had to restrict ourselves to the socio-demographic indicators and the economic part of it, the number of hospital beds and all those things. Yeah.
Right.
Not the severity, because what you are talking about would have.
Yeah, exactly.
So what you are talking about would have given us the severity of the disease. So that the government was not interested. They just wanted number of cases, number of beds, and number of ventilators they can handle it. Severity, yes, probably those SNPs could have helped. But then again, we didn't have the baseline number of the distribution,
that's what I
allele frequency of those SNPs in the population. That was another catch.
Exactly. Yeah. So government never funded for these things.
No, it depends.
No,
Of course, that's what I was saying. There is a gap. There is a gap.
Different.
But it's not that it doesn't happen. It happens, but you have to work. That is the cost effectivity comes in. Anyways, we can have this outside the webinar, I guess.
Yeah, sure. Sorry for interviewing. Do we have any questions for our Spain team, for our doctors from the Spain team? I think we have well exceeded the time. So if any questions to them, we can pose, or else I think we can end this webinar. Sure. I think there are no further questions to all of us. I would request the coordinators from the AID side to call this thing off. Once again, thanking you all. Thank you very much. And with a big, big Indian namaste to all to the Spain team, the doctors from the Spain team. Yeah.
Thank you.
Thank you. That's fine. Fine. Thanks.
Bye.
Bye.
Thank you.
Thank you. Namaste.
Thank you.
It was a
Thank
pleasure.
you.
Thank you. Thank you all.